Well, hello, everybody. Good afternoon or good morning, depending on where you are in the country. My name is Garrett Schmidt, and I'm the CEO and managing editor of VBC Exhibit Hall. And I'd like to welcome you all to today's live webinar hosted by Roji Health Intelligence. And it is called Running into the Federal Health Care Budget Crisis. Can Value-Based Care Save You? Very interesting and timely topic today. I'm excited to hear from our host, who I will introduce momentarily. But a few items of note before we get started, just some housekeeping items. Everyone has joined today in listen-only mode, so this is a traditional webinar format, so you don't need to worry about turning off your camera or microphone. It's not like a Zoom thing. But we are going to have a time for some Q&A, and so we want to hear from you. And that will be towards the end of the presentation. But if you have a question at any point during the presentation, go ahead and ask it. And you can use, there's a little module that you have as an attendee to drop your question there. We're going to get to as many as we can in the time that we have. If for some reason we're not able to get to yours, don't worry, someone will reach out via email to make sure that we answer your question. And then finally, the session today is being recorded. So I would say about an hour or so after we conclude, you will receive an email, and there will be a link to the recording as well as to where you can download the slides, because I've been able to preview the slides, and there's a lot of material there, and you're going to want to have those to review later on. So you will be able to do that at the link that I send you. All right, without further ado, I want to introduce Ms. Terry Hush. She is the CEO and co-founder of Roji Health Intelligence, and she will be our presenter today. So welcome, Terry.
Thank you, Garrett. It's very exciting to be here. And who knew several months ago when we scheduled this topic that it would be so timely. So I'm very excited to get your impressions about the federal budget situation in healthcare, and then have a lively discussion after the presentation. But we, as Garrett said, lots to say here today, and so let me get started. A little bit about us and where we stand in this space. We are squarely in the value-based care space. We have tools for cost as well as quality reporting. And so this is a heart and soul for us. So let me start with a little quote that I think is pertinent to today's discussion. And I actually have a little pair of quotes. And this is from Elon Musk. So failure is an option here. If things are not failing, you are not innovating enough. And here we have somebody flying off the cliff. We don't know what's below, but we assume that there is water below ready to catch them, which is not what I think some people feel at this time. And then the counterpoint to that is failure is not an option. Apollo 3 landing mission control. And here we have some people up on a cliff, and we know that water is probably not below there. And this is probably the situation that many of us in healthcare feel, that there really is no possibility of failure that is not going to hurt the system and hurt the people who are our patients coming to us. So it's something that I would like to keep in mind as we talk today about what will work and what won't work in the months and years ahead. But first, I'd like to get a little bit of a perspective on where you're sitting in this, which is a polling question: do you believe there will be huge budget cuts in federally funded healthcare? And our two little images here, we have a burning forest, and then we have a juggling up in the air question. So A, answer that no, that won't happen, or B, yes, preparing for it.
Okay, so you should see this on your screen. And as usual, go ahead and choose one of those two. And just so you know, and we have another polling question later on. These are anonymous, so you can feel free to play along at home if you would like. And we will show the results here momentarily so you can kind of see where you stack among your colleagues. So do you believe there will be huge budget cuts in federally funded health care? No, that won't happen, or yes, preparing for it. So it looks like most of the results have come in. I'm going to close it down in another 5 seconds here, and then we will show you the results. I wonder if you can guess what they will be. All right, here we go. I'm going to close it down and share the results. Terry, um, we have 3% that says no, that won't happen, and 97% of our respondents said yes and preparing for it.
Yep, I would ditto those responses. So for the 3%, I still think that's kind of an interesting number. Maybe it's pretend. Maybe you just wanted to be interesting.
We can all
So,
hold out for hope.
pardon?
We can all hold out for hope.
We can all hold out for hope. And here we have the first section slide. We're going to go into some of the federal cuts, and this kind of portrays where I am. Just believe it. And let's dig down into, I'm a budgeteer in my past lives. And so I come at things from a financial perspective generally, and I want to tunnel into the federal budget and where things are actually sitting. So if you look at this overall pie chart from the Kaiser Foundation, you see that healthcare, which is purple, accounts for about 27% of the total budget outlays. And that includes healthy portion of Medicare, Medicaid, the Accountable Care Act. Most of those are small in the 2% range. If you magnify that as a total amount of discretionary spending, you'll see that healthcare is really where it's at in terms of healthcare and Social Security, in terms of the possibility of actually having enough money. Looking at that purple piece of the pie, here's how it breaks down. There's a mandatory spending percent that includes Medicare, Medicaid, ACA market subsidies, other mandatory programs. Then there's a tax subsidy component. This is what is our forfeited taxes because the employers are providing health insurance. So they get a break on taxes, and that's about almost $400 billion. And then there's a small discretionary spending part, which is veterans health, NIH, and a lot of the high profile programs that we've seen being cut in the last couple of weeks. So 80% of federal health spending pays or subsidizes health insurance. That's an important thing to understand, is that we're always talking about where we cut is in the area of health insurance. And here's another thing that I think is important to recognize. Those cuts and what we're cutting deal with the current population. They're not dealing with what we're going to be seeing down the line. So right now we have about 63 million people on Medicare. But in 2060, that will be 94 million, which is quite a bit bigger and will consume even greater amount of budget. So a lot of what we're seeing is looking forward to higher growth in the population itself and escalated costs. In terms of what is actually being changed right now or what's on the table for funding, first you see a lot of payments that are made to academic centers and to hospitals that are in a substrata of the Medicare program. So the NIH research funding for an academic institution, that could be as much as 30% of the entire bottom line. But for those who are not doing academic research, it will be zero. Then there's site neutral payments to hospital, which is a kind of a formula that Medicare cost reports use, or phasing out the Medicare payments for bad debt. So this impacts people in poorer areas or for high profile treatments. Reducing or eliminating payments for uncompensated care. Again, you're dealing here with uncompensated or uninsured patients, or situations that are so expensive that they exceed the parameters of someone's health insurance. Then we get into some of the Medicaid cuts. So the Medicaid block grants, the floor on cost sharing, the per capita cuts to the program, the elimination of the expanded Medicaid program, and then a few other things that affect the situations like eliminating the tax exempt status for not-for-profit hospitals. Most hospitals are not-for-profit. If they had to pay taxes, then that would be a hit to the bottom line of the hospital. And then, of course, eliminate the models that funded value-based care infrastructure. So we've already seen some of that this week, and we'll go into that. Then there's eligibility changes. You can change the eligibility requirement, the expansion program for the eligibility, and that will just wipe people off the rolls and therefore eliminate the federal funding and state share in Medicaid's case for that. And then there are the actual cut of particular services like home and community-based services. Those are all things in the general proposals that are being talked about right now. So where does this hit? The hardest hit are the hospital and hospital-based systems, especially those in poorer areas. There are some exemptions that are folded into this. If a hospital is really in distress, they don't get as much of a hit in some of those items as in others. Rural areas are somewhat protected as well. But in general, hospital and hospital-based systems are the target of most of the actual on the table proposed cuts right now. Now, keep in mind, we haven't gotten very far in the process, and there will be a lot more cuts on the table, and some of them could go a lot farther because, as we all know, the cuts that are on the table right now will not fund the tax cuts that are also on the table. So there will be an attempt at some point to dig deeper into healthcare because there we are, we're out there with a lot of money in the federal budget. Academic hospitals are severely impacted. We see all those that have been housing research from the NIH are going to be impacted. That's going to be a big hit for them. The residency program pullback or the share of residency program graduate medical education cuts are going to impact the academic hospitals too. And all providers with high Medicaid or high uncompensated care are also on the line here. So what does that mean for the overall system? Well, as much as we like to think that the doctors are the leading edge of the system, and they are, the funding for most of the system is still coming from the inpatient side. Most of the money that we spend out in Medicare and Medicaid goes to hospitals, not doctors. It is a growing share of prescription drugs, of course, which we would know. But hospitals are really at the very center of what's going on with patients losing coverage will impact hospital bottom lines, residency program cutbacks, it will impact hospitals, the loss of the ability for that revenue to fund the physician base when we have a growing physician supply will be an issue. And those are all access issues. What they will result in is longer waiting times and the disability of some people to get access to the system at all. And then there is the quality and treatment side of it. When you affect funding, you affect access and the availability of certain treatment modalities for patients. And you will also affect the providers that are surrounding a major part, a hub of the system, who are referrals and linked providers who will also feel the cuts. So there will not be a part of healthcare that is not affected, even if the cuts are limited primarily to those that affect hospitals. So the question we need to ask is, well, can health systems make up for cuts? And the answer to that is really no. There were 72 mergers last year. 30% of them involved at least one distressed partner. Yes, we know there's waste in the systems. Yes, we know that the consolidations of mega systems is going on and has raised costs, but can the system make up this level of cuts? It is probably not possible. Even if they start consolidating middle management and things that we know will be happening throughout the system, the level of those changes are a one-shot deal at budget cuts, and they won't have the long-term effect of reducing the overall total cost of care. So the question is, can value-based care help or hurt you in this situation? And my retort on that is, do you actually have another choice on the table? Because I think what we're really talking about is a reduction in the total cost of care. That's the only thing that will start getting us out of this mess that we're in of the overall escalation in healthcare costs if we start taking costs seriously. And up till now, value-based care is, we've looked at health equity, we've looked at quality, but we haven't really dealt with cost. And that's going to change radically, is changing radically. We saw the first 4 payment models go down last week. Primary Care First was already on its way out. It was in the last year and it was being replaced by Making Care Primary. But 4 models, which I would have chosen as probably the most likely to be eliminated in this group, will be ending by the end of this year. I know the blurb says it's saying $750 million in savings coming from this, and I just want to see the numbers on that, but it's being cast as a savings mechanism, not as a value-based care turnaround. The statements anticipate that value-based care will be evaluated based on reducing costs. This is a huge shift when what we've been talking about is access and healthcare equity and social determinants, and a lot of the programs of the last year focused on getting care out, doing better with what we have, but not on actually cutting money out of the system. And just to look at the quote from CMS, if you don't believe what I'm saying, the statutory goals of reducing program spending is where we're headed. So where does that leave us with the value-based care payment models? Because those are really the vehicles under which value-based care actually exists. Well, there are still all the various ACO models, which is a really important thing to recognize. And these are the primary care components right here. And then that includes the MSSP still in play, ACO REACH still in play, Vermont all-payer ACO model, which is a regional model, obviously, as is the Pennsylvania Rural Health model, and ACO Primary Care Flex. I was a little surprised to see that still on the table, but I think it meets a need of a particular type of ACO, and this may not be the end of the process yet, but so far we have ACOs still alive. So let's just take a step back, look at what's ahead. So we've got the emphasis on limiting costs that we've just talked about. The investment in primary care is not a government line item. And why do I say that? Because those models that were eliminated, Making Care Primary, for example, primary care models, were specifically focused on helping primary care gather the infrastructure they needed to manage under a value-based care program. And now that's not considered a government responsibility to fund. The other thing I think we see from the elimination of these particular models is that they were pretty long-term, 10 years, 10 and a half years for primary care, for Making Care Primary. And I don't think in this environment that there's an appetite for looking for long-term improvements. We've been practicing enough. We've been practicing ACOs since 2012, and I'm sure it is time to start really working on the savings. Obviously, we're going to be seeing some big changes in the infrastructure in the federal government to support all these models. I think that's another issue that's on the table. Less CMS staffing to oversee the multiple and complicated models. So reducing models, putting more oomph in them would be the way to deal with that. And way less interested in helping to shape the healthcare system or helping providers get on board with these kinds of things. I think we're going to see a much firmer approach: get in, or you don't get the money. And then, of course, we already know from the discussions out there just isn't a lot of interest in having the government play such a big role in the healthcare business. So there's a great feeling out there among some people that government should just not be in the business of healthcare. So my little future telling here, and you can take what it's worth when we're like at a carnival. So ACOs will continue, but I would predict that we're going to see downside risks scale up and dominate the market in a much shorter period of time. I'm not sure this whole glide path will survive the way it is. I think there'll be more, as I said, oomph behind some of the ACO models. If ACO REACH survives, it will have to save money. If it doesn't save money, it probably will not survive, because it could be easily classed as another DEI program. Specialist episodic models will grow and be mandatory without question. We've got 40 to 60% of costs that are consumed by specialty care, and that is something that we've been tackling on the fringes. I think that that will start to be front and center, and that will be a major force that we're dealing with over the next couple of years. Also, and this has been pretty much stated by the GOP, Medicare Advantage is set to grow. It's already over 50% of the Medicare program. There's a great belief it kind of pairs with the government should be out of the business of health insurance, and who should be better situated? Medicare Advantage. So I do expect that to grow. There will be a lot of consternation about that, and we'll see where it goes. And providers will probably have to participate in these payment models to survive, unless the world just breaks apart into a private and public system, which is also possible, but probably unlikely. So let's look at this Medicare Advantage thing. Why does the current administration like Medicare Advantage? How does it fit into the philosophy of smaller government and healthcare and so on? Well, it gets the government out of insurance, the insurance business, as I mentioned. That's a big draw. It's easier to limit costs when you have one lever. When you can pay capitation payments to MA plans and do it on the side, it's a lot lower profile. I mean, having been in the public budgeting process, you don't want to draw the attention. You want levers that you can not have to go into reconciliation budget and filibuster and shutting down the government. You just quietly lower the costs for Medicare Advantage plans. It's an easy budget fix. And it's a limited cost because they are capitated. It fits into the privatization strategy. It decreases the federal employee count because they don't have to manage all the traditional Medicare programs and the ratings and figure out what the cost is and evaluate all these benefits and evaluate all these programs. for people interested in clearing out the federal government bureaucracy, this is a big draw. And then, of course, it distances the government from activities and claims denials. So you don't have a good cop, bad cop. So how do you work in this environment? Because this is a really big shift. I don't think I have to tell anybody that who's listening in on this session. Well, first let's look at the CMS value-based care models that have provider cost control potential and still exist. So you've got several in the ACO area that are based on per capita or episodic reimbursement. There's ACO REACH, but it's not really open at this point to new applications and may not be. There's TEAM, which is the surgical model of episodic payments, mandatory model, but right now it's restricted to a couple geographic areas, and it may grow really big in order to do that. There's the enhancing oncology model, which deals with a very high cost arena, is paid on an episodic basis, and I think is something that is likely to continue or grow. And then there's the ACO PC Flex program, which is just getting started, just been announced. Maybe that will make it. It's hard to tell at this point. And then there's the MSSP ACO, which is a savings model, has a bunch of different tracks in it. Some of them have risk, some of them don't have risk. I think that there will be potential in those programs to adjust the level of risk and find what the federal government wants, which is a fix on a cap for costs. And then, of course, there's Medicare Advantage. If it's strategically focused, it will provide value as well as lower cost. So let's look at these specialty models first. The single specialty focused payment models, right now we're only left with enhancing oncology care model because the kidney care choices model was canceled last week along with some of the other payment models. The enhancing oncology care model is a really interesting one. We'll go into that next and look at some of the features of that program that will likely dominate not just cancer care, but a variety of different programs. The difference with oncology, of course, is that you're dealing with a condition that is very long term, has lifelong, as a matter of fact, and patients can return back into treatment, can evolve into treatment. So it's not something like, it's more akin to looking at chronic illness, but a very high cost of that, as opposed to looking at something that's a procedural model. And then there's the transforming episode accountability. These are specific surgical models, and we'll look at these two and what features might be used to expand programs. So enhancing oncology care, it's a chemo model. It's paid on an episode performance above or below cost. It's measured by both cost and quality measures. It is, these episodes are 6 months long. In order for a provider to really evaluate the cost, however, those 6-month timeframes, which are very arbitrary and capturing patients wherever they are in the process of the chemo, are not very helpful to them to figure out where their cost overruns are. So really, it requires a lot more than what the model provides for oncology providers to zero in on why they have admissions and ER and so on. So you need to have a specialized analytics interface in order to participate in this model with good results. But what's good about it? What's important about this program? Well, first of all, specialty-based payment model. That's an important thing because this is such a high driving cost area, and it focuses on coordination of the patient needs beyond cancer treatment. So in order to keep the patient out of the ER, in order to keep the patient from developing complications of chemo, you really need to be on top of what's going on with that patient and anticipate the situation before they get into that bind. The other really important thing here is that practices get claims data. So they can see everywhere the patient is going, they can see all of the situation that the patients have gotten into, and they can stratify their patient risk so that they can deal with those issues. It allows the building of clinical episodes beyond the 6 months for comparative analysis of costs. You can, once you have that claims data together with the clinical data, you can see where the outliers of patients are and what is driving those patients into those outlier sections. It also puts practices at financial risk because they are paid a set fee for that 6 month. Now, team, different kind of thing. It's mandatory for those geographic areas. You don't need to try out to these teams because you're getting drafted into it. And I expect that this is the way it will actually grow beyond the 5 areas, is that people will get drafted into team by virtue of being in a particular kind of surgery case. It's a 5-year mandatory model with risk tracks scaling risk up. The hospitals have to participate in these as well. And there are 7 procedures, including several in the lower extremity joint replacements, spinal fusion, surgical hip femur fracture treatment, coronary artery bypass graft, and major bowel procedure. So you see across several specialties here, a lot of history behind these already. And so this is why I would say I would be surprised if this doesn't move into a faster track towards risk and expansion, because BPCI, I can never, Bundle Payments Care Initiative, Bundle Care Payments Initiative, preceded this for a number of years. Of voluntary programs for these surgeries already existed. Then it moved into mandatory joint replacements and so on. So I think that there's been a lot of practice here. I would not be surprised to see this move into a mandatory payment model on a larger scale and quickly. So why should you, at this point, looking at your slice of the pie, even consider value-based payment models in 2025? Are you taking revenues away that you might not have to take away? Or are you actually building the capability for participating in the system in a stronger way? Well, when you faced worse than this, we just came out of the pandemic, and you knew what was going on at that time, where you didn't have the resources to be able to deal with the influx of patients. What we're dealing with now is anticipated, and it's a way of changing the financing of the healthcare system, but it's a doable process. You simply have to know where all your data is as a start. If you want to build and sustain into the future, rather than turn into a ruin, really the organizations that get this under their belt and move forward quickly and start adopting risk, it fires up the organization, and you will be able to build that into the future. If you're on the end of this process without the practice that you really need to get started, then I think you've got a different situation, and it actually impairs your organization from getting a hold of this. You're also at the pinnacle of excellence. You still have all these years of buildup of expertise and research and so on behind us now is the time to be able to use those expertise to actually build models that can work in the future. The benefits for all ACO models is that you've got enhanced predictive payment. You've got claims data, which is just so valuable. You cannot get that for commercial insurance yet. I hope that everybody who is listening to this will start negotiating their ACO contracts with insurance in a way that will ensure that they get or work with insurers to get that claims data, because it is obtainable. You just have to be negotiating it. You have the attribution of patients to you, so you have a ready body of patients that you can work with should you choose through an ACO. And your physicians get a bonus. For now, I don't expect that to continue for a long time, but they will get a bonus for now. The assumptions are, in accepting those benefits, you also accept downside risk. You aggregate your data so that you actually know where your costs can be reduced, and you take action to reduce them, not in one program or two programs a year, but wholeheartedly put your steam into cost reduction. The bottom line is that an ACO can and will be beneficial to you if you successfully meet cost criteria. You don't, I don't think they'll survive. I think that they will be cut from the program. Benefits for specialty models, well, it positions your specialty physician for much better referrals, because you can use that same kind of program to market to private industry, to market to employers, as well as private insurance companies. And it gives you a leg up to do that. It provides predictable revenues. You have a particular amount. You don't have to hassle over the detail of what that is in your amount for surgery. It comes in a very predictable way so that you can bank that. You have the ability to use that data to reduce cost variation, because you do get data back on these, and to identify overruns. It gives you leverage with other specialists, especially if you are in an ACO, for example. You want your specialists to be participating in payment models, because negotiation is just behind this. Negotiation of specialty rates will be happening. It's another prediction of mine in the specialty payment models. It's been put on the table before, and it's moving through that kind of getting ready phase. You can use specialty care models within and outside the ACO once negotiation is allowed. And it's smart to be a part of negotiations of that with the private health care plans. It gives you the ability to actually identify how good your deal is with the private healthcare plan, because you have something to compare it to. The assumptions, again, you build episodes of care so that you can identify the variation in cost drivers and work with your specialist to reduce those. You've got to be able to really be able to identify where things go wrong, and whether it went wrong because the patient was just a train wreck to begin with, it came in a trauma circumstance or something else, or it was simply a wavering of a clinical pathway that went wrong, or whether there was something that could have been prevented. What is that, and how do you prevent it from happening again? Other smart strategies that you could deploy to deal with costs. First of all, if you own an MA plan and you're negotiating with MA plans, reconsider that. Think about it. You're in conflict here, and it doesn't really work to be in conflict to own a plan and negotiate with MA plans. Providers are going to have to be a lot narrower in who they choose to do business with on the insurance side. And why will that be? Well, there's a cost to it. There's a cost to doing all of your negotiations. There's a cost to the infrastructure that you have to manage the payments that come in. under the layers of networks and health plans that you're operating with. And there's a value that you can't dismiss to having a very solid negotiation strategy that is not a come-all to your organization. If you have an ACO and you're negotiating with MA plans outside your ACO, meaning that you are not using your ACO as your contracting entity, think about that again. You're fighting against yourself because what's your ACO doing? Managing just Medicare? If your ACO is managing just Medicare, your ACO is underperforming what they could be doing for population health and your interventions to put you in better cost situation. If your ACO includes specialists, especially high cost specialists, orthopedic surgeons, neurosurgery, cardiac, reconsider because it's upping your cost profile. If you have a patient with heart failure and all they're seeing is their heart failure doctors and not their primary care doctors, you now have an attributed patient who has a much higher cost level than your other patients. Same goes for people who fall a lot or who have orthopedic injuries constantly. I happen to be one of those. I would hate to be attributed to an ACO when I'm only seeing the orthopedic surgeon. So think about your overall cost of your ACO and how your panel may actually be raising your costs. Develop solutions to getting your data more easily and sharing with physicians. If you have a physician-led ACO or you have a lot of physician groups on your ACO and you have gazillion systems, some are archaic systems to gather data from, that's increasing your costs. And so you need to help develop a solution for those practices that saves money for everybody and gives them better value for their data. And then you need to develop your organizational strategies to tackle costs. If you don't have an infrastructure that does something with the data after you've gotten it and identified what the problem is, then you're missing kind of the point of that whole process. So, road forward, a yellow brick road going forward. Central organizational strategies to cost control. First of all, it's been a long time coming, but it is time to pivot the organization to value-based care. If you are paying and compensating your providers on volume and not on value, and you're not pulling in cost as part of the exercise, then you will not win at cost control. Secondly, aggregate data for value-based care and cost management. If you're not aggregating data at this point, and not just from your central part of the organization, but your larger network, then you really can't perform. And that includes claims data. Then you really can't perform effectively on costs. That data, however, just can't sit in a repository and somebody perform analytics on it. It needs to be curated. It needs to be validated and curated, and you need to be able to look at same comparisons to develop cost variation examples and identifying the history of a given patient case that ended up on the outlier and all the drivers that took it there. Don't wait to build your pipeline for improvements and intervention for your processes for patients. Even if those pipelines are send it back for clinical review of what this patient has happened here or what this patient is going for. If you've got a case with in chronic disease where your outcomes are just same old bad, and you're not moving towards a reassessment of what to do with that patient, then it's time to change. And share data with your providers. It's especially cost data and patients for that matter. I think that's going to be something that we really see as important in the future. Share data so that you can actually get people vested in what you're trying to do under value. Major ways to pivot organizationally. One of the things I mentioned is to adopt clinical teams. If you are, there is no way that you can really align with value-based care unless you have population health and a strata of programs and evaluations under the lead physician for that patient. Much more people involved. It just means reorganizing all the people you have into teams that can manage in practices. Adapting initiatives in response to patient needs. I mean, it's a long time coming where we've actually listened to consumers and what they want, and they want price transparency that is not like a price listing of all your various line items. They want to know, what will it cost me to have my gallbladder removed here? Changing compensation to match your value-based care goals, essential. So here we come to the second polling question. So I want to see whether you believe me on all these things I've been saying today. And the question is, will value-based care help providers survive cuts in the next 4 years? And of course, that's by reducing the total cost of care, so implied. Yes, there will be an adjustment period and then growth under value-based care. And no, we're going to be cut to the bone.
All right, you, as before, will see this appear on your screen. So go ahead and select one of the two answers here. Will value-based care help providers survive cuts in the next 4 years? Yes, there will be an adjustment period, then growth under VBC. Or no, we're going to be cut to the bone. And the answers are still coming in. And okay, I think most of them come. We'll close in about 10 seconds here, and then we'll show you the results. Close in 5, 4, 3, 2, and 1. Okay, Terry. So 82% of our listeners said yes, there will be an adjustment period, then growth under value-based care. 18% said no, we're going to be cut to the bone.
Okay, well, that's a wonderful number of optimists in the audience. I think that's terrific. And for the 18%, well, come back next time. We'll talk more.
We'll dash your hopes then.
No, we won't, because we'll just have more toys to figure out. So let's just wrap it up. I have a couple things to say. So just wrap up all this discussion here. Thank you for sharing your perspective on this twice too. Value-based care is definitely pivoting to cost. It's not about anything else right now. Cuts will be deep. They will primarily hit hospitals and academic centers, but as we saw, that will then diffuse out throughout the system. Everybody will suffer. Payment models are already changing. The carrot will disappear. The stick will be coming. Plan for shifts to capitation and episodic payments and away from fee for service. You have to give it up. You have to give it up. I'm sorry. ACOs especially must facilitate changes in systems and practices among disparate practices. You've got to have a nucleus of change in the organization. If your ACO isn't strong enough to take on that challenge, or it's just, then reinforce it, make it work, because the ACO, I believe, will be the only way that providers can stay afloat in the market and not just be on the receiving end of negotiations with the insurance company. The ACO can be your agent for change. And then I'm ready for questions. Don't make them hard,
Okay.
though.
Yeah, no, we've got a lot of questions today. We've got pretty big audience, so we're going to get through as many as we can. If you have a question for Terry, go ahead and submit it now using your control module there as an attendee, and we're going to get to as many as we can. So, in no particular order here, let's start with this one. I'm hearing of health systems dropping their MA plans and assuming it's due to the reimbursement from these. If MA is slated to grow, then are independent providers going to care for the patients?
Well, that's a good question. If if hospitals drop their MA plans, I think they're going to be renegotiating their MA plans shortly. They're probably dropping them because of cost, and they won't have a lot of places to hide because of the prices will be dropping for all reimbursements, and MA will just be one of those places that has lower costs. So I don't foresee a situation where they won't be able to care for the patients or the patients will have to go elsewhere. I think right now they've got kind of a problem, a short-term problem. That's all.
Okay. Uh, Next question here. Oh boy, let me take that one apart here momentarily. Okay. Where do prescription costs fall in relation to inpatient and doctor costs?
Prescription drug prices are very, very high. I can't give you the exact dollar, but they're probably closer and getting closer to hospital costs, if not exceeding them at this point.
Okay. Uh,
And
Next
and
question.
it is
Oh,
worth
go ahead.
noting that
Yeah.
that is not an item on the table. It is worth noting that. In fact, has been taken off the table in terms of cutting the budget.
Mhm. Okay. Next question here is, do you think value-based care can help solve the current physician feeling of being overwhelmed with reporting responsibilities that are taking time away from patient care?
I think the value-based care, if I think the internal structure pivot that I'm talking about can be very helpful to physicians who are overburdened with documentations of all kinds and management of everything from getting price information to doing their clinical work to everything else. But there's a lot of stuff around the physician at this point that is not helpful. And there are a lot of things that are coming about like natural language protocol and less documentation needs and so on that are helpful. But much more needs to be done in terms of the middle layer of clinical management around physicians to support that physician in good care.
Gotcha. All right, next question is, do you think adopting advanced primary care management will hurt or benefit a practice participating in an ACO?
I think the advanced primary care management concept is what the ACO is supposed to be doing.
Hmm.
And it just providing a better fee for that, which is, it makes sense because the primary care fees are too low. Specialty fees are, you know, in general engulf the primaries. So I don't see a problem, but right now it's a separate fee and a fee for service system. Don't see that continuing because I don't see the fee for service structure continuing long term. So once you move that into a capitation model, the capitation fee takes into account primary care management of that patient.
Okay. Next question, and it kind of begins with a statement. Says, why do we think that a breakdown of U.S. healthcare into private and government funded healthcare is so unlikely? I see the rise of concierge primary care and increasing numbers of patients getting care through FQHCs and community clinics as an argument that a breakdown to a bipartite system of cash pay primary care in FQHC or community clinics for primary care. So the question is this. What is your opinion on the massive spike in concierge primary care in recent years, and do you think this will continue and worsen the primary care shortage?
Hmm. Really, that's an excellent question, and I don't know really at this point. I've just been recently surprised by learning that most of my friends pay for a concierge fee, and to me, I was just flabbergasted that everybody was paying for a concierge fee. Yes, I think it's really likely that in the short term, you will find concierge practices growing, and you will find a willingness to separate out the system. Look at the demographics. The demographics alone tell you that it will be virtually impossible to have a bifurcated system in the future. Now, will it be like the UK? In the UK, there's private insurance on top of the government mandated insurance. And people who want to also go to a private doctor or who want to speed up the process will go to a private practice. Will people with adequate resources want to do that still? They will still want to do that. And that will probably exist, just like people who want to go shop at certain stores and can afford to shop at
Mhm.
certain stores will do that. Will there be a feeling that that is an unfair system? Yes, maybe, hard to tell. So I think there will always be room for that, but will it be a major feature of our system so that doctors will drop out and exist only on concierge fees type practice? I don't think that the room in the system exists very much for that. And I don't think it will exist very much for that because there's going to be other things that are going on besides healthcare that impact that.
Great.
That's just
We have
my perspective.
no, yeah, that's a lot.
Really hard.
Yeah. Okay, we have time for one more question, and unfortunately, we're going to wrap up here. But again, if you asked a question that was not answered, don't worry, someone will reach out to you. So go ahead and ask it now if you got one, and someone will get back in touch with you. The last question is this. Will out-of-pocket cost ceiling $2,000 for pharmacy 2025 change for 2026 and beyond, or do you know?
Out of pocket costs under what? Under private plans, I mean, the donut hole. I'm not really sure what the question refers to, but will out of pocket costs go up? Yes, out of pocket costs will continue to go up for patients as well. Drug out of pocket, maximum out of pocket, all out of pocket care will be higher.
That's what I was afraid you were going to say.
Yeah.
Uh, all right. Well, Terry, thank you so much. This was a fantastic presentation, as usual. And we got some really wonderful comments about how fun and knowledgeable you were in this presentation today. And hope that you join us in the future for another one. But as we close out, wanted to encourage you to head over to bbcexhibithall.com and check out the Roji Health Intelligence virtual exhibit booth. And Terry, yeah, there you go. You should see that on your screen, and there will be a link directly to it in the slides. And you can go there and check it out. There's a lot of great resources, and you can read up on them and what they're doing, and of course, reach out to Terry and her team through there. Also, feel free to reach out to me, and I'm happy to facilitate an introduction directly to them. And the other thing about BBC Exhibit Hall, this is where the webinar is going to be stored or archived. So if you wanted to visit it later in our library there, you'll be able to find this webinar along with a bunch of others from Terry and others as well. And then finally, if you would like to reach out to the Roji team, Terry and Leonard's information is here on this screen. Feel free to reach out to them directly. And again, if I can facilitate an introduction, I'm happy to do that. Thank you all so much again for joining us today. Join us on the next one. And until then, we hope you have a wonderful rest of your week. Take care. Bye-bye.
Thank you.